Welcome everyone to the 2023 PI Conference. My name is Emma Mertens and I will be your moderator for today's session, Common Variable Immune Deficiency or CVID Overview. Dr. Cunningham-Rundles could not be here today in person, but has graciously filmed today's content. At the end of the presentation, we will also include a Q&A portion based on the most common questions IDF receives regarding CVID. If you have additional questions that do not get addressed in today's session, we also encourage you to visit our Ask IDF platform, and we'd be happy to follow up with you individually. Charlotte Cunningham-Rundles, MD, PhD, is the David S. Goetzman Professor of Immunology, Professor of Medicine, and Professor of Pediatrics at the Icahn School of Medicine at Mount Sinai in New York. She established and directs the Immune Deficiency Program at Mount Sinai, a leading referral service to evaluate and treat infants, children, and adults with a variety of primary immune deficiency diseases. She serves on the medical advisory boards of the Immune Deficiency Foundation and the Jeffrey Modell Foundation. She is a longstanding member and is currently an officer of the Expert Committee on Inborn Errors of Immunity of the International Union of Immunological Sciences. Welcome, Dr. Cunningham-Rundles.
So today we're going to talk about common variable immune deficiency. And that's one of the more common types of primary immune deficiency, as you'll see in a moment. And what we're going to discuss is going to be the signs, the symptoms, the testing, the diagnosis, treatment, and then what other resources and other topics would you like to think about. So first of all, this is just a picture of an antibody-making cell, which is being trained to recognize either by a vaccine or by an infection to become a plasma cell to produce a great deal of antibody will then circulate in the blood. And this is kind of the basis of the common variable immune deficiency issue. So what happens with these antibody making cells when they get to their full maturity is they make gamma globulin. So one of the questions you might like to ask is, well, what actually is gamma globulin? So gamma globulin is a group of proteins that are present in the blood plasma, and they contain all the antibody that you need to defend against any kind of foreign substance in the body. That would be a virus, it would be a bacteria. And that's a mixture of different gamma globulin molecules, and they're all produced by white blood cells called these B cells. And that happens in response to an infection or a vaccination. And what they do is over time, they turn into finally the cell over here on the far right, which is called a plasma cell. And this is kind of a grown-up, mature, ready-to-go B cell. Now, of course, those cells belong in the immune compartment. And this is what the immune system looks like when you have stem cells that turn into lymphocytes called T cells, or it turns into a lymphocyte called these B cells, which then mature to produce the gamma globulin. And this is the area where common variable immune deficiency is categorized because this whole limb of the immune system is not working very well, or in some cases, it's really not working at all. So there isn't any gamma globulin in the blood, or there's really not nearly enough in order to fight infections. Now, this is just a picture a child drew about what B cells do. And in a way, it sort of tells you the whole story. And I find it quite fascinating because, of course, he's just a child. But he's pretty much got the issue here, which is that B cells, which for some reason here are saying beep, beep, I don't know why. But what they're doing is that they are then killing this nasty virus, which is in red, and killing this nasty bacteria over here by making all the gamma globulin molecules. And that's what this picture is here. It's a B cell making all the gamma globulin molecules, which are then now all over the surface, and they're getting ready to be shed to do this amazing job. Now, common variable immune deficiency is relatively common. That's the interesting and curious thing about it. If you take the incidence of primary immune deficiency diseases and say, of all the patients that come to the office with an immune defect, this is really one of the most common immune defects. In my own practice, it's about 30% of the patients that I see. But honestly, this is the same number that you would see if you look at a major textbook about immunology as well. So it's interesting that this particular grouping is really quite large. Now, it has a definition, as you would expect. In other words, we have to know what we're looking at. So when you're first getting diagnosed with an immune deficiency, one of the things that we do is we try to categorize that and make sure that we know exactly in which category that person is best described. And so the way that we describe common variable immune deficiency is by, first of all, a marked decrease of the IgG antibody molecule. And usually, both of the other isotypes, or the other types of gamma globulin, IgA and or IgM, or even both, are also quite low. And the other thing is that remember that infants don't have that much gamma globulin producing capacity. And so we generally have to wait until at least the 4 years of age in order to be sure that what you're really looking at is not just physiologic immaturity, but in fact, that child will end up having not really enough gamma globulin in their lifespan. And then the last portion of this is then you have to think, okay, there is no gamma globulin, or there is very little, but what is made, is it functional or is it really not working? In other words, is there any reason to suspect that there's a poor response to infections or vaccination, or maybe that whole process is completely eliminated? Now, the other thing about common variable immune deficiency is that a physician is always having to think, is there a chance that this is due to something else? In other words, could it be due to a medication or another ailment? And that's why the gamma globulin level is so low. And so you always have to keep an open mind to think whether there's any reason to think there is really something else you have to take into account. Now, I mentioned before that common variable immune deficiency is common, but the honest truth is we actually don't know how common it is. Some of the textbooks say 1 in 50,000 people, but it's probably much more than that. It's probably at least twice that number, at 1 in 25,000. And if that's true, then that means that there would be about 14,000 patients in the United States. And I don't even know if that's true. To me, that may very well be also quite an underestimate. We honestly don't know. But here's a picture of what the gamma globulin levels look like. And so this is about 1,800 patients. This happens to be data from USID-Net that was sponsored by the Immune Deficiency Foundation, of course, as well. And that is that the levels of gamma globulin are really quite low. I put the normal ranges over here on the right. So if a person has an IgG level of 210, then that would mean that the normal level would be 600 to 1,200. So they really are quite deficient. Now, it's quite a bit of a range, and that's true for normal people as well. So being 210 or 250 or 400 or even 10, for example, all of the people in that category would be described as having common variable immune deficiency. The IgA is very low as well. And as you can see, the IgM is low as well. So this is kind of the general picture in the United States. Now, the other thing in the United States, and these are patients of mine from Mount Sinai, is that for some reason, most patients, I would say, not all, but most, are actually adults at the time that they are diagnosed. Females in this particular group of patients, which was somewhere around 400 and some patients that we saw at Mount Sinai, the average or the median time at which the diagnosis was made was actually 39, which is not really a childhood situation. It's true that 20% are under the age of 21, but on the other hand, these are generally speaking going to not be children. There always will be some that are under the age of 20, males or females. And by the way, they're a little bit more commonly going to be a male, described a little bit earlier. But it's one of those diagnoses that often is delayed, as you can see, delayed really quite dramatically in some cases. We don't understand why that's the case, but we do know this is true for all the medical offices that any of us have ever thought about or collected the data. And one of the reasons for that, of course, is that we do know that diagnosis is delayed very, very commonly, somewhere around 7 to 8 years after the first characteristic medical event. This is a common phenomenon to have someone be sick for some years and then finally someone figures out what was wrong. Now, when it comes to the usual medical history includes infections, and that's generally going to be the major reason for making the diagnosis. That might be pneumonia, it might be recurring sinusitis, bronchitis, or any combination of all of the above. The second most common phenomenon would be, for us at least, autoimmunity. And it's very strange because I don't understand and have thought about this a great deal. When you're autoimmune and you don't make an antibody to the external environment, but you don't mind making an antibody to some component of yourself, it seems very contradictory, doesn't it? There's no rationale to that that's easy to explain, but there's an immune dysregulation component here, and that can sometimes give you gastrointestinal disease, perhaps cancer, asthma, for example, lung disease, large spleens, and then some inflammation in the lungs, and then, of course, granulomatous disease. And all of these occur in patients with common variable immune deficiency. When it comes down to infections, I think sinusitis is probably number one. The second most common one is probably going to be pneumonia, bronchitis, and perhaps also ear infections. All of these would make a great deal of sense. And people listening to this probably understand exactly the numbers of these that can occur, sometimes for years before the diagnosis is finally made. Shingles occurs, bloodstream infections, meningitis, cellulitis, and in a very few bone infections have occurred as well. This is a very typical picture, and there's many things I don't understand about this. This is a 40-year-old lawyer, and he's previously healthy. He had a second episode of pneumonia, and he developed the area called empyema, which means that there's basically fluid around the edges of the lung, which you can see in this X-ray over here. And then, curiously enough, he's really almost agamma globulonemic. But as you can see, he's 40 years old, and he doesn't have any gamma globulin. And so one of the things you ask yourself is, well, how did he get away with that? How can you manage to be 40 years old, go to law school, medical school, college, and the rest, and then somehow really have no gamma globulin in your blood? It's very, very contradictory, isn't it? And we don't know really how to explain that. It's just that every once in a while, I will see a patient exactly in this category. And most likely people listening too may also know of someone similar who's in the same category. Whether the B cells failed more recently, and that's why we have these very low levels, or whether they slowly failed over time, these are the issues that we don't know. This is another common finding on X-ray, which is called bronchiectasis. And what that means is that the bronchial tubes are now scarred, and these are the scarred areas here, these white lines inside the lung fields here. And this particular woman as well was 28 when she was diagnosed. Her levels are extremely low. And her first CAT scan shows this picture here of chronic lung damage, but it had not been recognized previous to this time. She was something of a smoker, and I think people thought, well, she's a smoker, and maybe that's what happened. But as you can see, that's not really the story. The story is she's almost agamma globulonemic. And mostly that's due to this set of infections over here on the right. These are other pictures. Lung disease can be a very, very major problem in hypogammaglobulinemia. That's because the lung has really got to be fighting infections continuously. And every person on this picture here has some scarring in the lung, as you can see. Some of them really extremely extensive, such as this woman over here. And so this is what develops over time, and that's what we always are so interested and so eager to be sure exactly what the lung is telling us when we first see a patient. Now, as far as treatment goes, I think everyone knows what the treatment would be, which is that if you don't have gamma globulin, of course, then you need gamma globulin. And the original doses were given was 300 milligrams per kilogram every 4 weeks. That was the first dose that we ever used. And then over time, the doses became higher, 400 to 600 milligrams per kilogram body weight every 4 weeks. And then subsequently, subcutaneous infusions of gamma globulin of similar amounts were developed. Again, a very marked improvement in quality of life. And then finally, facilitated immunoglobulin infusions, again, of similar amounts every 4 weeks. And so all of these are extremely satisfactory. They all have the same efficacy profile. And as you know, what we generally do is decide which of these is going to work the best in an individual patient. But what I can tell you that over time, these higher doses of gamma globulin have caused the levels of gamma globulin in the blood to increase over time. This is a paper from Uwe Bowman, who then put together data from some previous publications. And these are the so-called trough values. In other words, the lowest amount that a person has when they walk in the door for their next infusion. We're expecting a higher and higher level in the blood. But as you can see, that's also correlated with fewer infections. So this was Mount Sinai data in 99. This was the French data of 2008, and this was Mount Sinai's data in 2011. So again, we don't expect to see recurring bacterial pneumonia in our patients with common variable immune deficiency. Now, that's a wonderful phenomenon, and it's wonderful to be able to say that, but then it also says, well, what else do we need to know? Well, for 700 of our patients with CVID, I have to say that infections are one thing. On the other hand, there are other things which are what we call non-infectious complications, which have developed and now become sort of our major area of work, I would say, not only in the lab, but also in the clinic, which is that we still do see autoimmunity. We still see lung disease, lymphoid hyperplasia, and very, very big spleens, gastrointestinal problems, liver disease, granulomatous disease, and to an extent, lymphoma and other malignancies. And so these are the areas that we spend a great deal of time talking about and thinking about currently, research-wise and also otherwise. Now, autoimmunity is something I said a moment ago, which is that if you can't make an antibody to measles, mumps, rubella, tetanus, diphtheria, and pneumovax, why does the immune system think, okay, fine, I'll make an antibody against my platelets, my red cells, my skin, maybe my pancreas, my white cells, thyroid, and so forth. It's very, very odd, and it really has been difficult, and of course, a research opportunity to say why is there autoimmunity in a person who's not making antibodies to those external bacteria and viruses very well. And that's something which is a very much of a research topic we're interested in. In terms of autoimmunity, these are the commonest autoimmune ailments, which is usually low platelets, which for me is about 25% of my patients have had low platelets. Evans syndrome is the combination of hemolytic anemia and thrombocytopenia or low platelets. That's the combination. Some rheumatoid arthritis, antibodies to IgAs, some lupus, alopecia, where one loses one's hair, diabetes, and so forth, moving down the list. So autoimmunity is something which we do spend a fair amount of time thinking about in common variable. Now, infections could also, in effect, be not only the lungs, as I mentioned a moment ago, but it could also be the intestinal tract. And so that's going to be bacteria, viruses, viral infections, bacterial overgrowth. And these will be the major organisms that we tend to see in patients with common variable immune deficiency. It's really a collection of ailments, some of them extremely troublesome. For example, in particular, more recently, norovirus has been a problem for us. But the other problem in the intestinal tract is simply inflammation. It's not due to a bacteria or a virus, but it's inflammation, which then gives you areas of patchy inflammation, swelling of the intestinal tract, lymphoid hyperplasia, so that each one of these little nodules here is a lymphoid follicle, which is extremely large. This will be an area of inflammation in the intestinal tract. This is an area in which the mucosal surface has really gotten to be completely overgrown here with lymphoid follicles, and then frank inflammation, a little bit like Crohn's disease in the intestinal tract. This is about 8% of the hypogammaglobulinemic patients will have something with the gastrointestinal tract that's more or less a problem. And it can be quite a problem in some. One of the things to remember, too, is that the immune system not making enough antibody, in many cases, what will end up happening is the spleen and the lymph glands also become large. So this is a spleen here. These are very large spleens in these particular patients here. In this case, the liver is large, the spleen is as well, but the liver is increased, and it's also in a way kind of wrapping around the top of the spleen here. So we find this very, very commonly in the hypogammaglobulinemic patients as well. And again, it's the spleen, and I always look at it like a filter, which is trying its best to do a very good job. And in fact, it's increasing its surface area, trying to do that job and do everything it can in order to keep the blood in good condition. So what do we do about these inflammatory complications? And this is not a slide to exactly memorize, and it's not complete, but it gives you an idea of some of the ways in which we combat the inflammation in common variable immune deficiency. And honestly, we borrow our therapies from other specialties. And so the anti-inflammatories might include steroids and oral steroids similar to that used in Crohn's disease. In fact, all of these therapies here on the top are actually used in the Crohn's disease circumstance. Some of these are used in Crohn's disease as well, and others are used when there's inflammation in other organs. And all of these we've been borrowing from our colleagues and our other specialties in order to use these when we do need them. And many of them have proved extremely helpful, as you can see over here on the side. Some of them are more experimental than others, and they're still undergoing trials. Fusion proteins and others, JAK inhibitors, and some of those used in rheumatoid arthritis sometimes find it themselves to be extremely helpful in patients with common variable immune deficiency. And so these are the therapies that we use, as well as gamma globulin. Gamma globulin, unfortunately, does not do the entire job, and that's why we have to use these additional therapies sometimes. But the major question in your mind, and in my mind for many years, of course, is that's great, but why did the B cells stop doing their job? Why did they forget that they're turning into a plasma cell? Why? What is the issue here? The B cell is supposed to turn into a plasma cell, which is then like a factory pumping out gamma globulin. And that, of course, does not happen. And so we don't get that gamma globulin in the peripheral blood. So what is the issue? What is the problem? So we spent a lot of time thinking about that. And of course, on the one hand, you could say, well, there could be a patient who simply doesn't have those antibody-making cells. That's number one. It could be that those cells don't get activated, or they could get activated, but they don't mature, or maybe they mature, but they don't make it all the way into a plasma cell. And then even if they did become a plasma cell, perhaps they forget to make all the antibody that you really want. So there could be these 5 stages of difficulty, and each one of those could be an area where things really come to a screeching halt. So we spent a lot of time thinking about genetics and trying very hard to sort of dissect out common variable. And in a way, that's finally paid off, I would say, to a certain extent. It's not gone all the way, but it's helped us a great deal. You may not know, but again, this is the plan of how a B cell matures in the bone marrow. The patients who have a disease called Bruton's X-linked agammaglobulinemia, the gene was first found in 1993. And for hyper-IgM syndrome, the same year. But common variable and these antibody defects and IgA deficiency and just IgG deficiency, all of these really took a long time, another 20 years before we had a really good idea about what was actually going wrong with the immune system. Why is this the case? And finally, as you can see, over some time, these genes here in yellow finally were clarified. So it's true that finally over time, it became a little bit more obvious exactly what is the problem with patients with common variable. The first ones were discovered in 2003. And since that time, there's been sort of a cascade of these genes that have finally been identified as being, oh, that's why the gamma globulin isn't being made. Now I understand. Now, looking at our patients at Mount Sinai, not to tell you the name of every gene, that would be too much. But at Mount Sinai, we have about 29% of the time that we can now say this is connected to your hypogammaglobulinemia. Many of these genes were somewhat of a surprise. For example, the NF-kappa B1, like, why is that presenting in the clinic as a hypogammaglobulinemia? And this, of course, is an area of really quite a bit of research in the lab to say, well, that's the reason why, but why? And so we have to sort that out. And the other side of the coin is that even if we now know for 29%, that doesn't take us all the way to the end zone, does it? I'm still very much wanting to know, well, that's great. What about the other 70%? Now, this is true in the United States, but if you look at the United States here on the far left, and then in Sweden in the middle, and then over on the far right, this is Iran. These are all sequences that were obtained from patients in these 3 locations. You can see that, in fact, there are different genes in each location. Some of them overlap, but some of them don't. And the bottom line is that there are actually 56 different genes in the 601 so-called CVID subjects. And so it really takes at least this number of genes. And as I say, that's not the end of the story. There's going to be more. It takes very, very large number of genes for you to make an antibody, any kind of antibody. And that's fairly stunning as to why does it take so many genes to make antibody? Just the antibody making B cell certainly has a certain number of genes, and we understand that, but why does it take so many? And one of the reasons is this complicated picture, but if you look at it, the point of it is that it is complicated, which is that a developing B cell has to go through a lot of activations and transiting through the lymph nodes, go through the center of the lymph node, and finally has to develop enough activity along with T cells to develop really a functioning memory plasma cell out the other end. And it really takes all of these interactions to get from point A to point B, or I should say point A to point Z, actually, because there's really so many areas along this pathway that could go wrong. And that B cell just doesn't have the education it needed to become a fully functional, mature plasma cell. And that's the reason why it takes so many genes. It's not easy. And if you take those genes and say, well, tell me where the breakdown occurs, you can actually take each one of those genes and sort of paste it onto the area in which it's broken down. And again, this is a little bit of a simplistic idea, but I think you can see how this could work, is that the plasma cell depends upon many, many interactions throughout this entire point all the way through. So genetics has really helped us a lot, but it hasn't finished the entire story for us. It hasn't told us everything we want to know. And I think one thing you'd like to know first off the bat is, well, when do you use genetic testing? So first of all, I'd like to say that it's not required for the diagnosis of CVID. CVID is based on the things I said a moment ago, the antibody, the gamma globulin in the blood, thinking hard whether it could be something else, and that's it. That's where the diagnosis come from. Genetics testing does cost something. And remember that we may not be able to find the gene. Now it's only about 70% that we will not find it. About 70% we will not find it. But in a few cases, the gene can suggest some helpful therapies. That does happen. And sometimes it might be helpful in family planning or in family care. And I've seen this occur as well. But in a way, the basic treatment is not going to alter. Patient is still going to be on gamma globulin, perhaps antibiotics, and maybe some of the other therapies I talked about a moment ago. So it probably is not going to change everything for most people. We do find it useful, but on the other hand, you have to remember, if you don't really want to have genetic testing, your therapy is really going to really pretty much stay the same. Now, what about monitoring? How do you know what you have to do, and how do you get what observed? And these are some of the monitoring that most of us use. And that is that if a person has had just infections with these common pneumonia, joint pains, perhaps pneumonia, there's certain common ways of checking that out periodically. Usually for us, every 6 to every 12 months, we'll do a blood count, we'll measure the gamma globulin level, we might do an X-ray, we might do a culture, for example, if something is needed. If a person has previously had low platelets, then of course you're going to be checking the platelet count, perhaps every 6 months, perhaps a little more often, depending. In some cases, you might need a bone marrow. In most cases, you don't, but on the other hand, it could be something that might be wanted. For enteropathy, when your GI tract is misbehaving, you really want to be sure that you're getting all the vitamins that you need, that there's no bacteria that you need to know about, that your B12 is okay, that there is no bacteria that's present or virus that's present. You might need an endoscopy in order to check. That might be a colonoscopy. And then nutritional studies would be very important as well. Calcium, for example, iron, B12. What if a person just has these lymphocytic proliferation? Then we may need to check the lungs. We may need to check out the lymph nodes from time to time. It's not impossible that a biopsy might be needed in order to clarify that. And then going down the list, if there's other areas that have to be observed, then for bronchiectasis, check the chest, make sure the breathing is okay, the abdominal ultrasound to check the size of the spleen, something called a fibroscan to be sure that the area of the spleen is not causing too much portal hypertension, and again, perhaps endoscopy. So these are the evaluations that might be needed. And many of these, of course, are done in common medicine. They don't have to be done every 6 months in everyone, but they would have to be done at whatever interval seems the most reasonable based upon the patient's prior history. So in conclusion, common variable is one of the most common of the immune defects. And usually what that means is there's too many infections. On the other hand, there might be an area of something else, low platelets, for example, or some other form of autoimmunity, perhaps gastrointestinal problems. And the treatment, first of all, is going to be good amounts of gamma globulin, either IV or subcutaneously. You're going to use antibiotics very, very frequently, prophylactic antibiotics possibly, or treatment when needed. And then, of course, we've been borrowing these biologics from our colleagues to treat autoimmunity and inflammation. Genetic causes are known for about 30%. And it's, by the way, I'd like to point out that's age dependent. In other words, not just children we test the genetics on, we check plenty of adults as well. And sometimes that's helpful for understanding family illnesses or family planning. But in most cases, you don't actually need the genetics in order to understand what you're going to do. Some cases, it might give you a clue about most treatments, but I would say generally it doesn't. From the lab, though, it tells us something about why do B cells work? Why do they work and why do they fail? And of course, that's from a standpoint of research, something that our patients are teaching us. We're learning that from our patients, to be very honest with you. And I think we've learned a lot about it, and there is more to learn. There is no question about that. So I'd like to acknowledge a good number of my colleagues at Mount Sinai and other locations. Rockefeller University has been helping with the genetic studies, University of Michigan, Stanford, the Karolinska, and of course, my colleague at the Yale University, who then subsequently has moved also to Stanford. So thank you very much for coming to this session today, and I hope you have some nice questions.
Wonderful. Well, thank you so much, Dr. Cunningham-Rundles, for sharing this important information with our community. My name is Emma Mertens. I'm the Program Manager of Community Health at IDF, and leading us through the Q&A, we have Dr. Charlotte Cunningham-Rundles from Mount Sinai Medical Center. Before we begin, please remember that everyone's treatment and condition is unique. The information presented during this session is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. All right, we've gotten some great questions so far, so we're going to get right into the Q&A. All right, the first question is, this individual asks, what is the difference between hypogammaglobulinemia and CVID? I noticed that I have both diagnosis codes listed in my chart.
That's a very good question. And it has something to do with the fact that hypogammaglobulinemia is a little bit more of a generic term saying the levels of gamma globulin are low. It doesn't tell you why, it just says they're low, and that could be intestinal loss, or it could be that person is just low because it's a child and the physiologic levels are still low. Common variable would mean it's a little more of a precise term, which means not only are they sort of low, but now we've tested those antibodies that are present in the blood and they just really lack antibodies as well. So it's just a question of what the insurance company also is going to be paying for. Hypogammaglobulinemia is a little bit more of a generic term. Common variable immune deficiency is a little bit more precise, and sometimes the insurance company wants a little more precision for coding.
Thank you. Great answer. All right, next question. What are the criteria for a CVID diagnosis?
The most important thing is the levels of gamma globulin IgG and IgA or IgM or both. In other words, 3 of those types are low. And you also have to be shown that the material that you're making is not good stuff. In other words, the gamma globulin might be present in the blood to an extent. The levels might be a little bit low, but if the antibody function is correct, then it means that it is not common variable immune deficiency. I always think a little bit like the octane of gas. In other words, you can have really high octane, or you can have gas, I suppose, with no ability to drive a car. It looks like gas, but it isn't really gas. And so that's the way I look at it. I don't know if that's a good analogy or not, but that's the proof of the pudding has to be that you just don't have the ability to respond to a bacteria or a virus by either by vaccination or perhaps an infection that you've had.
Thank you. All right, next question. My doctor has diagnosed me with CVID and wants me to start infusions. I am not someone who gets infections. Why would I need IVIG?
Yeah, that's always a tough one, because if you have not had an infection and your IgG level is pretty awful, you know, it's a little hard to convince somebody to do it. On the other hand, as they say, the ground is very firm up to the edge of the cliff, right? And the edge of the cliff is not exactly where you would like to be standing, according to what I would suppose. So if the levels are really quite low and the antibody is missing, then I would not wait for an infection to occur. After all, that first infection could be one that lands you in the hospital with the need of a chest tube, perhaps meningitis or a bone infection or a bloodstream infection. So most of us are a little bit wary about running that risk.
Thank you. Next question. Can you please explain the vaccine challenge and explain how long is the wait time from having the initial vaccine to getting your titers checked?
Well, the vaccine challenge really is exactly that point of trying to say, you don't have antibody to pneumococcal bacteria or Haemophilus bacteria or shingles, for example, or measles, mumps, or rubella. But it could be that, in fact, the time that you had that vaccination, or maybe you never did, you know, your body wasn't ready for it. If you were a child or an adult, perhaps you never had those vaccinations. And so the idea would be to say, listen, here is this bug. Can you make an antibody, please? Just tell me. And in about 1 month would be when you'd start to look. We don't look sooner than a month, but you could look a month or 6 weeks or 2 months. The point is, did you make antibody in the right amount of time? And can we prove that you actually have this capacity? So we usually use about 30 days, but it doesn't have to be on that exact moment. 4 weeks, 6 weeks, it really wouldn't make much difference.
Thank you. Next question. I still get sick even though I am on infusions. Is there anything I can do to boost my immune system?
That's a particularly tough one. It depends on what the infections are, whether it's gastrointestinal or whether it's respiratory. We have used quite a bit of prophylactic antibiotics in some patients, partly because if there's been prior lung damage or the lung has not got perfect capacity of resisting bacteria, sometimes we use azithromycin, for example, as one of the prophylactic antibiotics. We've been adopting that routine of using azithromycin 3 times a week, for example. Others have used Bactrim every day in a half dose is another reasonable alternative. The other thing is maybe not boosting the immune system so much, but also being absolutely sure that the dose of gamma globulin that you're already on is satisfactory. And of course, that would be perhaps either at the end of the month or during the course of the week, checking to be sure that level of IgG was extremely satisfactory and not on the borderlines of not particularly useful. So I would first start with that particular idea, I think, and then moved over to the area of prophylactic antibiotics.
Thank you. Next question. Having CVID, am I at a higher risk for cancer? If so, how often should I be screened?
Well, the truth of the matter is that there is a higher risk in common variable, and the literature does tell you that. And the question is, well, what screening would one do? The commonest type of cancers that develop actually is lymphoma, and that is one that we think about quite a bit. But if you look at the data that was put together, I guess around 7 or 8 years ago, is that also skin cancers were something to notice, and ordinary everyday cancers that occur in humans, such as stomach or colon, or for ladies, breast cancer, are really somewhat increased as well. And so going to your internist and having a routine check and doing the routine evaluations is certainly one of the important things. So that's just a routine matter of having your internist check you. With regards to lymphoma, that's tougher. So that's one that's not easy, because any lymph node that's present doesn't need to be repetitively biopsied to check if it's okay. as I mentioned before, those lymph glands are going to be enlarged in common variable immune deficiency very often. And it could be that one does have to have a biopsy at some stage to check it. But generally, that doesn't require repeated biopsies going back and back and back. From our experience, routine X-rays, possibly a CAT scan, are useful. PET scans are less useful because those lymph nodes are already very active, and they are really not quiescent the way that you would expect a normal lymph gland to be. They're in the process of being active. And so I don't think PET scans work so very well. Now, how often would that be? Yearly, perhaps. One would have physical examination at least. We don't like to over radiate people, so we don't do very frequent radiation. We don't do very frequent CAT scans again, because we are aware that there could be previous reports of some radiosensitivity in CVID. So we're a little bit cautious about repeating. I would rather have a person have a physical examination and then, rather intermittent, rather 2 or 3 years study of those lymph nodes that are swollen. And that would be what I would suggest.
Thank you. I think we have time for about 2 more questions.
Okay.
The next one is, can I infuse when I am sick?
You can infuse when you're sick, but you're more likely to have a reaction. So if you're sick, but you're not in the first few days of being sick and you've been on an antibiotic for say 24, 48 hours, you probably can. If you have a person who's coming down with pneumonia, I know from experience that that is not the time to get an infusion of gamma globulin because you risk a reaction. You could say, well, how would you avoid that? You could just go extremely slowly and just make it like an IV infusion that was very slow. And by the way, I'm talking IV infusions. If you're sick, the subcutaneous infusions probably don't matter very much, because remember that the gamma globulin is entering your system very slowly, only trickling in from the skin. So I'm not really thinking the subcutaneous gamma globulins are part of the problem here. It's really the IV versions.
Thank you. And our last question, if I've been diagnosed with CVID, should my family members also be tested?
That's a tough one, because less than 10% of family members are ever found to be affected. So if there's absolutely no clinical history that's suggesting, I don't think there's a special rush to test. That is one of the reasons why the genetics could be useful. In other words, if there was a genetic situation, then the family member would be tested most likely for perhaps if genetics indicated that it was one of those genes that could be inherited, then that would be a person that would be probably tested to see whether that gene was really creating common variable immune deficiency or not. But most family members actually are not affected. It's less than 10% of any family I've ever seen. It's pretty uncommon. If there's a family history that's suggestive, of course, then you would just check the gamma globulin levels and a few antibodies, and that would be putting everyone's mind at rest that that wasn't the case too. So that would have that benefit.
Wonderful. Well, thank you so much, Dr. Cunningham-Rundles. Our time together has come to an end. Thank you so much again for putting together this wonderful presentation. It has been an honor to have you join us today.
Thank you very much. Thank you very much, Emma.